Hello, everybody, and welcome to our Neela lunchtime webinar. For those of you that are joining us for the first time, welcome. This is one of a series of webinars we have been doing and will continue to do for those involved in the care of patients having emergency laparotomy. So today we're going to talk about sepsis and emergency laparotomy, and I'm really pleased that we've got some fantastic speakers today, and I hope that you'll be able to contribute to a discussion and debate after we hear from our speakers. Please do that through the chat function and as we go along and towards the end. So I'll introduce all of our speakers in turn and then do a little bit of housekeeping. So my name's Dr. Carolyn Johnson. I'm a consultant anaesthetist and I'm the QI lead for Neela. And I'm joined today by Dr. Ron Daniels, who is also a consultant anaesthetist working in intensive care, and he is the lead for the charity Sepsis Trust. I've also got Dr. Narani Savayaham, and she is a consultant in emergency medicine and the Trust Sepsis lead at St George's Hospital in London. And also we've got Miss Lindsay Pearce, who's a consultant surgeon and a colleague of mine on the Neela project team. She is the Neela surgical and research lead. So before we start, there should be a Q&A tab that you can see that you could submit any questions and comments through the tab there. If you're having any IT problems, I've got no other advice for you other than to turn it off and on again. So just exit and restart Zoom tends to sort most of these things out. A recording of this webinar will be up on the Neela website in due course after we complete. And we have one CPD point applied for at the Royal College of Anaesthetists, and that CPD certificate will be emailed after the webinar. And please, for our benefit, I'd ask you to complete the post-webinar survey so that we know how to make these presentations a bit more relevant and better for you in the future. So I'm going to start today giving you a little bit of background on what the Neela data shows around patients with sepsis having an emergency laparotomy. And then we've got a few more dates coming up in the future. So save the dates. 22nd of November, we'll be talking about our annual report, which is approaching completion, isn't it, Lindsay? We're nearly there. The findings of the annual report. And then on the 13th of December, we're going to talk through the emergency laparotomy patient journey. So really looking at the full journey for patients from start to discharge when they go home. So on to Neela and sepsis. So I'm going to talk you through some data from the previous Neela report, which is the 6th report, and that is data from December 2018 to December 2019. This covers all emergency laparotomies done in England and Wales, of course, that have been entered into the audit in this time. So that shows that 25% of all the patients who come in, who qualify to be submitted to Neela, who come in needing an emergency laparotomy or laparoscopic bowel surgery, 25% of those patients have signs of sepsis, and 20% of them have signs of peritonitis at admission. And we define sepsis in the annual report based on the NEWS2 score. So that is a score of over 5, or if you have a score of over 3 in any single variable. But we also include other diagnostic indicators of sepsis. That is patients who have signs of peritonitis or perforation at presentation. And what we know about these patients is that nearly 93% of them, the vast majority, are recorded on the audit as needing urgent surgery. And that 85% of them arrive in theatres within the correct time frame. And this number is stubbornly consistent. So over the previous years of the audit, and I've got a not very nicely formatted table, but I've got a table there that shows you that we've actually been extremely consistently hitting 94.4, 94.4 and 94.8% of patients arriving in that time frame over the previous years of the audit. And so whilst we've seen things like mortality improve year on year, and we've seen length of stay improve year on year, and we've seen consultant delivered care and admission to ITU improve year on year, this is a metric that has been stubbornly hard to improve. And what we know from, sorry, let me get my slide back. Yeah, from some other data is that there are other bits of data that are also stubbornly hard to improve. So this table shows the number of patients with sepsis at admission, and that's interestingly decreased over the years from about 30% of patients down to 25% this year, which was on my opening slide. And a consistent number of those don't have the administration of antibiotics recorded in the NELA data set. Now, those of us that record NELA data and trudge through the records as local NELA leads might know, because some of this data is quite hard to capture, isn't it? When patients are admitted through ED and may have separate ED paperwork, for example. But that the mean time and the median time to antibiotics is also a subject of some concern. So the mean time to antibiotics is between 17 to 24 hours. And so some of those patients have got their antibiotic delivery delayed by significant amount of time. And even if we look at the mean, even if we're not looking at the number of patients that skew that, the mean time to antibiotic administration is 3.5 hours, and the interquartile range starts at 1.4. So fewer than 25% of our patients are having patients with sepsis suspected at admission are having antibiotics within the required timescale, which would be 1 hour. So this data is subject of some concern, and it hasn't changed through the years, and so that's part of the reason why we're talking about it today. And then what about the outcome for these patients? So 71% of them are cared for in critical care, which is what we would expect, I guess, with sepsis and emergency laparotomy puts you in a pretty high risk group. And the mortality for the 30-day mortality for these patients is actually extremely high. So 15.1% 30-day mortality. That is in comparison to 9.3% mortality for all patients coming for emergency laparotomy. So as you might imagine, the patient with sepsis is a higher risk patient than most other patients having an emergency laparotomy. And so with somewhat concern, we see that this mortality hasn't dropped like the mortality for the general emergency laparotomy population, but has actually risen slightly in the last few years, from 14.1 and then down to 13, but then up to 15.1%. So just to indicate what you can do to look at your sepsis patients on the NELA dashboard, if you're a user of the NELA QI web tool, you can see that there's a sepsis dashboard on there. And that dashboard gives you a lot of different information in a very granular way about your patients with sepsis. So if you look at that dashboard, you can see patients who've, the number of patients who have had their antibiotics within an hour, and also who haven't. Those that reach the operating theatres within a timely timescale, and that's defined by the surgical team when they see the patient, whether they're immediate category or urgent, and whether that patient's had their lactate measured. So you can see here on the chart, I've picked a good one from our data, the number of patients that access theatre in a timely fashion. Those that do are in blue, and those that don't are in black. So this gives you some indication across time as to how the pathway is going in your hospital if you're a NELA lead. And similarly, you can look up on that dashboard the case ID of patients who don't meet the required standards. So you can go back and you can look at those patients in detail to interrogate a little bit more about their other processes in care and outcomes. And there's also a table in there of patients who have operative findings suggesting sepsis, but that wasn't identified preoperatively. So again, you can have a look. These kinds of lists are extremely helpful if you're looking, for example, at morbidity and mortality meetings and these kind of things too. So I hope that's a very rapid summary of where we are with the NELA data and some ways that NELA can help you look at these cases in a bit more detail. I'm going to hand over now to Ron Daniels, who's going to give us a little bit more about the background in the treatment of sepsis. Thank you, Ron.
Thanks so much, Carolyn, and hello everyone. So I'm Ron. I'm an intensive care doctor with an anaesthetic background based in Birmingham. I will concede that I haven't given an anaesthetic for pretty much anything for 19 months, so I've been solely focused on intensive care. But I also run the charity, the UK Sepsis Trust, and I'm not going to talk about sepsis during or after laparotomy specifically, because I've been asked to talk about the national picture. And obviously, so much has changed over the last period of time. So I'll just bring my slides up. So just to remind people of the official definition of sepsis. So this is the Marinoff definition, coined in New Jersey in 2010. And it reminds us that sepsis is a life-threatening condition, of course, that's been described, arising when the body's response to infection causes tissue and organ injury. Now, we all know this, but it's really important that we communicate this to our public. This is not necessarily a severe infection. We all know that we can get sepsis from an uncomplicated UTI, but it's the immune system and to a lesser extent the coagulation system going into overdrive with sepsis, and it's that overwhelming inflammation that causes the damage. Recently, we've seen some data, and I'll show you the source in a moment, that allows us to sort of recalibrate, and this was prior to COVID-19, the number of people dying from sepsis every year in the UK, and it's huge. This is, of course, Villa Park, the home of Aston Villa, and it gives us some interesting context. It happens to be my local club. Breast cancer. Obviously, we need to continue to improve outcomes from breast cancer. It's around 11,000 lives lost a year. Bowel cancer, as many of you will know, slightly more, at around 16,000. But sepsis, we conservatively estimate to claim 48,500 lives every year in the UK out of 250,000 index cases. Now, again, I'll show you the data source, but the majority of your clinicians, you will know that some of these cases are double counted, and that's legitimate. Some of them will have had chemotherapy for breast cancer and have neutropenic sepsis. Some of them will have had an emergency laparotomy for undiagnosed bowel cancer, peritonitis and sepsis. But it's reasonable to double count, because even though for those toward the end of their natural life, intensive care might not be appropriate, the basics of intervention for sepsis, as Carolyn's spoken about, the antibiotics, the lactate, the source control, do remain important. Now, these are some interesting data that we brought out just before the pandemic. We know from multiple case series that 4 sources of infection in rich countries categorize 95% of episodes of sepsis. Pneumonia is the most prevalent, which of course can occur postoperatively, urinary tract, intra-abdominal, which of course is very relevant now, and skin and soft tissue, bone and joint infections. So we looked at hospital episode statistics data for 2017, and we took the obvious codes, not the minutiae. We took the obvious ones for those conditions. Now, these weren't the first coded diagnosis. So this doesn't mean people went into hospital with one of these conditions, but it was felt during their stay that at least their inpatient stay was complicated by one of these conditions. And it was a huge number that you can read for yourself. This is well over 30% of acute sector NHS workload. So we all know we're dealing with a prevalent problem. This is the data source I mentioned. This is the Institute for Health Metrics Evaluation over in North America. You might not have heard of them, but you will have heard of the Global Burden of Disease reports, and it's these people who prepare those reports for the WHO. And so they've announced just before the pandemic hit the West that 49 million people around the world every year develop sepsis and 11 million people die. And that gives us some really interesting context against some other conditions. And it prompted the WHO via their Director General, Dr. Tedros, to issue a press release in September of last year, reminding us that sepsis is responsible for 1 in 5 lives lost worldwide. I think we shouldn't not talk about COVID when we're talking about sepsis. COVID causes sepsis, that's clear. Those who are critically ill have sepsis. Around a quarter of ward-based patients with COVID satisfy diagnostic criteria for sepsis, and pretty much all of them in intensive care. A colleague in Belgium, Jean-Louis Vincent, who was the past president of the European Society of Intensive Care, wrote a paper recently, just an opinion piece, but he said something really interesting. Is calling COVID sepsis a case of semantics? And Jean-Louis argued no. It explains why the therapies that we know work in critical care are effective, the immunomodulatory therapies, the antibody therapies, the steroids, but those that we no longer use in intensive care are pretty ineffective because it's this immune system overdrive. So we don't use antivirals anymore in critical care. This is sepsis. And you can look at Intensive Care National Audit and Research Centre. And this really clearly bears it out. In the interest of time, we won't go into detail, but included in this slide are people requiring vasopressor support, inotropic support, people who are needing renal replacement therapy. That's not SARS-CoV-2 infection, that is sepsis, and it affects a majority of those in intensive care. Now, we can't also talk about sepsis without thinking of survivors. And we know that if we get this wrong, and it's in our hands to impact on this, not only might we cause lives to be lost, but we also might impact on recovery and subject these people to really several miserable years of rehabilitation. It's at least 40% have one or more of psychological, cognitive, or physical sequelae. And this interesting but small Scandinavian study, it's the only one that's actually looked at whether people return to work or not. And it found that in working age adults who'd survived intensive care unit admission with sepsis, 57% had returned to work within 1 year and 43% had not. So it's massively impactful. We've heard about long COVID. It's of no surprise to people working in the sepsis space that long COVID was going to be an issue. Our support team in the charity now support people also affected by long COVID because it's an entirely similar presentation. Yes, there might be a slight increased risk of pulmonary fibrosis. There's not actually much of an increased risk of myocarditis, but in general, the symptoms are the same and the recovery profiles are the same. Now, I've entitled this sort of penultimate part, how do we get back to the future? And we are now going to talk about some clinical stuff. I welcome that we use News 2 as a surrogate definition for sepsis, and it's what we recommend. But we need to remember that it is a surrogate. It's not, of course, an official definition of sepsis. That's a change in sequential organ failure assessment score, or SOFA score. But we can't measure that at the bedside. We can't even measure that in intensive care in a very controlled, resource-heavy environment. So we use surrogates. So we start our screening, and these are our screening tools for the acute sector. We have them for all facets of healthcare. They're all NICE endorsed. So these have formal NICE endorsement. They're the only tools that carry that. So we start with a patient who looks unwell or has a high News 2 score. We qualify it with clinical suspicion of infection, and then we look for a red flag. Now, the red flags Carolyn's described will include those single parameters on a News score that carry a score of 3 or higher. Sorry, a score of 3. But there's also some nuances in there. There's also some subtle stuff, like people who have had recent chemotherapy and so forth, and looking for skin colour changes. So NICE agree, NHS England agree, that if we have a red flag, it should empower us to act. Now, I'm just going to talk about the Sepsis 6 because it might surprise some people that the Sepsis 6 has changed, and it changed in 2019. Obviously, our attention's been diverted elsewhere, so we're about to begin to remarket the Sepsis 6 and start to get it invested back into healthcare. We've made some changes partly at the behest of NHSE, NHSI, but also in consultation with NICE and with the Royal Colleges. And the biggest one is step 1, ensure a senior clinician attends, which is obviously hugely pertinent to the NELA audit. Step 2 hasn't changed that much, correct hypoxia. Step 3 used to say measure lactate and blood cultures. It now says IV access, take bloods, full set of bloods looking for covert organ dysfunction, as well as for pathogen identification. Now, when we say give antibiotics, we were pushing for source control to be included there, but NICE pushed back against that. And I don't fully understand their reasons why, but of course, all the teaching, we need to ensure source control goes hand in hand with pathogen control. So to give antibiotics, to then give fluids, and then the further changes to monitor the patients using News 2, serial lactates, and urine output. Now, I just draw your attention toward the bottom of this slide, on the slight right center of your screen, that word variance. It's okay to withhold antibiotics if you're not sure. This is not a thou shalt tool, this is an empowering tool. So if somebody were to write there, patient has gallstones, they've come with an acute abdomen, they tick some sepsis boxes, but I'm waiting for the amylase to come back, I'm withholding antimicrobials, that's sensible medicine. We would support that, and any audit trail should also support that. I just want to focus very briefly on step 1, though, this senior clinician, and hopefully this will make those of us invested in the NELA surveys and audits slightly reassured that we're not alone. Getting a senior clinician to the patient is difficult. There's an NHS standard on this, clinical standard 2, saying that all emergency admissions must be seen by a consultant within 14 hours. But the reality is really different. These are self-reported data from hospitals to NHS England against that standard. And they show that if we're in London, we've got about a 2 in 3 chance of being seen by a consultant within 14 hours. If we're not in London, at the extreme in the east of England, we've got a much worse chance of being seen by a consultant. And the reason I share this is that's the rationale for having these empowering tools. If we always had well-performing senior decision makers at the bedside, we wouldn't need red flag sepsis. We wouldn't need the sepsis 6. But the reality is that we do. We made huge inroads across England, and there are different data for Scotland and Wales. Northern Ireland had done a little bit less work on this. But in England, of course, we had a commissioning incentive. Now, the devolved countries don't have that luxury. That's exclusive to England. But it allowed us to effect enormous improvement. And these are pan-hospital data, not just ED, showing that, for example, with antibiotics, we increased delivery within the first hour from a baseline of 32% to the dizzy heights of 80% in 3 short years. Now, we were accused in a letter to the Lancet, or rather NHS England were accused, of creating hype and hysteria around sepsis and doubling antibiotic consumption. I asked the authors of that paper where they got those data from, and it was the Royal Pharmaceutical Society. So, of course, we wrote to them and got the identical data table that they'd sent to those authors. And it was really interesting, the spin they'd put on these data. So commissioning didn't actually start in 2014-15, it started in 2016. And since that time, it is fair to say in the left-hand highlighted column that emergency department use of antimicrobials has increased significantly. But as colleagues will tell us, we are using emergency departments very differently. Patients are spending a lot longer there, and this is doses rather than courses. So it might be we're counting some double dosing in A&E. But it is interesting and on the face of it alarming. But if you now look at the right-hand column that are highlighted, it shows total hospital consumption of antibiotics. And that's barely changed at all. It's increased by 1%. And in both cases, larger increases were seen prior to any incentivization. So I would argue that actually what these data show us is that it's possible to incentivize early sepsis care without the adverse consequence of increasing antimicrobial consumption and therefore impacting on antimicrobial resistance. Essentially, we're moving the geography of antibiotics. The final part of what I want to say is to justify why we need to bring our public on this journey, because it's no good as delivering brilliant care to someone who presents with an acute abdomen if they spend 48 hours at home languishing, not knowing what to do. And the former Chief Medical Officer, Liam Donaldson, when we asked him to write a foreword for this article that we wrote, he captured this brilliantly. He said that some really important clinical issues exist in backwaters inhabited by academics and enthusiasts, and boy, do we need those people. But that the public and political space is the space in which things need to be for things to change. And he cited the HIV campaign in the 1980s as a good example of this. So that's where a small charity like ours comes in. We don't have an advertising budget in the slightest. We don't pay for any advertising, but we do have the ability to form relationships. So we will continue to get the message across to our public in clinical spaces, reminding them of the symptoms of sepsis and reminding them of the need to act rapidly. And in public spaces, the different message, a gentler message, empowering them to phone 111 or make an appointment to see their GP and just ask, could it be sepsis if they're deteriorating with an infection? And we'll continue to run with multiple agencies, with sports clubs, of course, with television programs and placing stories into traditional and social media. Last thing I want to say, Sepsis Savvy, we've recently launched it. Many people listening will have access into schools, community groups, youth groups, whatever. This is free messaging to deliver gentle education into those communities. It's a short online video, a simple online game. It's free to access and it's been really well received. So if you're interested in that, get in touch. I would maintain that together we can continue to save thousands more lives. And goodness knows what's been happening over the 19 months to these patients. I think the opportunity is now to work together to get it right. Thank you very much. And thank you for shining a light on sepsis still.
Thanks very much, Ron. I'm going to hand over with no further delay to Narani Savayaham, who's a consultant ED clinician in St George's Hospital, London, and she's going to talk us through their approach and the excellent results they've had looking after patients with sepsis. Thanks, Narani.
Thanks, Caroline. So if I can get my slides up, you'll have to bear with me, or it's a hard act to follow. Okay, so I'm going to talk about early identification and management of sepsis in our emergency department. So I'm going to talk about what we do for patients with suspected sepsis, the evidence behind what we do, and some of our outcomes, the SHIMI data.
Hi, Narani. I can't see your slides. Are you sharing them at the bottom of the screen there?
Oh, okay. Let me try again. Let me go back. I'm not sharing them. Share screen. Is that visible?
Brilliant. That's it.
Okay. Thank you. So just go into slideshow. Okay, so Carolyn asked me to go through some of the research work and publications that we have done around sepsis, and that's what I'm going to present. So we'll talk about what we do for patients with suspected sepsis, the evidence behind what we do, and the outcomes regarding the SHIMI data. So what we do is we give antibiotics within an hour for patients who we have defined as high risk, and that is patients with a systolic blood pressure of less than 100 millimeters mercury, those with a non-blanching rash, i.e. the meningococcal sepsis patients, which we rarely see, and the last but not least group is the patients with suspected neutropenic sepsis. And these patients should receive antibiotics within an hour of arrival. The patients who we screen for sepsis, we use the NEWS2 score. So if they have a NEWS2 score of 3 or more and have a history suggestive of an infection, and no obvious alternative diagnosis, they are screened for sepsis, so they would have blood tests taken. That would be full blood count, Usinase, liver function test, clotting, venous gas. And if they do have sepsis or an infection, then we give them antibiotics after blood cultures. But what we do expect is that every patient who has received IV antibiotics for the treatment of a suspected infection or sepsis gets stratified according using the RED score, which is a score that we have derived and internally validated. So the RED score stands for Risk Stratification of Emergency Department Suspected Sepsis. So that we published about 2 years ago. It combines the Q surface score. Many of you would have heard of the Q surface score. So that's a respiratory rate of 22 and above, a systolic blood pressure of 100 and below, and altered mental state. The presence of 2 of those puts the patient in a high-risk category. We have also included the simplified CNIST score, which is a score that we derived, validated, and simplified, and that is age of 65 and above, a serum albumin of 27 and below, and a INR of 1.3 and above. So for patients on warfarin or DOAC, we would score 0 for that, for INR. And the presence of 2 of those variables puts the patient in a high-risk category. Lactate, we have stratified to a score of 0 to 3 again. So anyone with a lactate of 2 or less gets a score of 0. Lactate of 2.1 to 3.9 gets a score of 1. And a lactate of 4 or more gets a score of 3. And that is the initial lactate that we use. And finally, last but not least, refractory hypotension. So those without refractory hypotension get a score of 0, those with refractory hypotension got a lactate of 2 or less after the fluid bolus, scores 2, and if the lactate is greater than 2, they're given a score of 3. So the red score is the cumulative score of all those 4 scores. So we did initially put them through a univariate analysis and followed by a multivariate regression analysis, and all 4 scoring systems were independent predictors of mortality. So we were able to summate them, and the score goes from 0 to 12. A score of 3 or more puts the patient in a high-risk category. The mortality rate, if all the variables are measured, mortality rate of a score of 0 to 2 is under 3%. So we implemented the red score on the 1st of March 2019 before the publication came out. And this is the result of 27 months worth of data. So this is over 6,500 patients, or under 6,500 patients. And this is all suspected sepsis. So this is not just abdominal sepsis, obviously, because the numbers are far too high. So we have the mortality rate for scores of 0 to 2 was 6.3%. But we have to remember that many of these patients didn't have all the variables measured in ED. In addition, this does include the COVID patients, and those patients did have a higher mortality rate, especially those with mortality rates, a red score rather of 2, where they were over 65 and had a high risk rate. So the mortality rate for scores of 0 to 2 looks like it's a lot higher, but that there is a caveat there. For other patients excluding COVID, it was well under 5%. Scores of 3 to 4, the overall mortality rate was 17.5%. Scores of 5 to 6, it was a 28.6% mortality rate, and scores of over 7, the mortality rate was just under 60%. What we know from this data, or from some unpublished data, is patients with scores of 5 to 6 had 25% of that population ended up in ICU. If we split that population into those with refractory hypotension, now we know that patients with refractory hypotension go directly to ICU. And if we compare it with those without refractory hypotension, the group without refractory hypotension and those who ended up in ICU, 75% deteriorated and ended up in ICU within 15 hours of leaving the ED. And as Ron's data shows that many of these patients would not have had a consultant review. So we have decided that patients with scores of 5 to 6 are very much the emergency department's responsibility, because they have a high chance of deterioration. So what do we do about them? By the way, patients with scores of 7 and above were being managed appropriately. These patients actually look sick, and our conventional way of identifying them worked. But it's patients with scores of 5 to 6 that were a lot more tricky. So what do we do with these patients? So scores of 0 to 2, we treat any organ dysfunction if it's present along the normal pathways. Scores of 3 to 4, yes, they have a high mortality rate, but the numbers are vast. So we have a treatment, or we prepare a treatment escalation plan for these should they deteriorate. But as I said, scores of 5 to 6 are much more serious. They have a much higher mortality rate, and they deteriorate much faster. So we have taken on responsibility for these. So if the source of sepsis is not identified, we perform a CT abdo-pelvis just to see where the source of sepsis is, and we refer them to ICU. And if they're not appropriate for ICU care, we certainly consider a DNA order and have that conversation early rather than later. And for patients with scores of 7 and above, they are all referred to ICU. And if they're not suitable for ICU, they have a DNA order. So that what we've spoken about is the patient variables that are associated with mortality. We then looked at what are the treatment variables associated with mortality. And this we published in the Annals of Intensive Care exactly a year ago. So what did we do? The treatments we looked at were were the time to antibiotics, the volume of fluid, and the MAP after 2 liters of fluid. So this is all patients. As you can see, we looked at over 2,000 patients. The median time to antibiotics was 48 minutes. Patients who survived, the median time to antibiotics is 49 minutes. And non-survivors, oops, why is I'm jumping? I think I've lost my, right. So for patients who, non-survivors received antibiotics sooner than the survivors. So on univariate analysis, this was significant. But this is because patients, the non-survivors, were sicker, they were more likely to arrive by ambulance, to resus, and they got the antibiotics sooner. The volume of fluid was 1 liter in both groups, and on univariate analysis, there was no difference. And as you can see, the red score, the median red score for the entire group was 3. For survivors, it was 2. Non-survivors, it was 4. And this was significant on univariate analysis. But when we did the multivariate regression analysis and the Cox proportional hazard regression, the time to antibiotics was no longer significant. The volume of fluid was, and of course the red score remained significant. So as a population as a whole, the time to antibiotics was actually not significant. We then studied the volume of fluid for patients without refractory hypotension, and we looked at them with refractory hypotension as well. So without refractory hypotension, a volume of over 2 liters was an independent predictor of mortality with a number needed to harm of 14. And this was all crystalloid. We didn't look at the difference, any difference between saline and Hartmann's, but everyone received crystalloids. This is a group of patients with refractory hypotension. So we did an analysis of the 117 patients with refractory hypotension. Survivors received the antibiotics at a median 33 minutes. Non-survivors at 46 minutes. I'm sorry, my slides seem to be jumping. This didn't reach statistical significance, but again, when we put it into a multivariate regression analysis, this was significant. So for patients with refractory hypotension, the time to antibiotics was significant. And the cutoff point was at 55 minutes, and the number needed to treat was 4, which is highly significant. This is a slide of study of patients who had received a minimum 2 liters of fluid. We did the same analysis, and the MAP after 2 liters of fluid. I'm not sure why this is jumping. The mean after MAP after 2 liters of fluid was significant. We drew a ROC curve for the initial variables that were associated. Sorry, we drew a ROC curve for the map, and the cutoff point was 66 millimeters mercury, and lower were independent predictors of mortality. Going back to refractory hypotension, what I should have said is that we also, as you know, identifying refractory hypotension can take up to 2 hours. So we looked at the initial variables that were associated with refractory hypotension, and the systolic blood pressure had the greatest area under the curve. The cutoff point at this for identification of refractory hypotension was a systolic less than 107. Now that's a bit of an awkward number. So we studied 110 and 100. Systolic blood pressure of less than 100 had a greater specificity for identification of refractory hypotension. So we set a safety net saying, if the patient meets a systolic less than 100 after arrival, say they come in with a normal blood pressure and then drop their systolic, then you have only half an hour to deliver antibiotics. So hence we use a systolic of less than 100 to deliver early antibiotics. So we worked with coding to improve the quality of our coding, and the outcome data, the SHIMI data for sepsis. We were making headway, and then in November, COVID, the second wave, struck. We did have a higher number of patients who were not appropriate for escalation. This does not include COVID, but there were also fewer patients with lower levels of sepsis. So it looked like our mortality increased, and then we are heading back in the right direction again. And the graph on the left bottom is the graph for pneumonia. Again, we're doing reasonably well with that, and patients with UTIs are also heading in the right direction. So in summary, we aim to deliver antibiotics only within an hour, only in a small group of patients, i.e. systolic blood pressure less than 100 and those with suspected neutropenic sepsis. We then stratify all patients who receive IV antibiotics using the red score to identify the patients who are at high risk of mortality, those with a score of 5 or more, and where the source of sepsis is not obvious, we do a CT abdo-pelvis, and we limit the volume of fluid. The QR codes for the 2 papers are there. Thank you very much for listening.
Thank you, Nurani, and thank you to Ron. I'll just ask Ron and Lindsay to put your cameras on. Thank you. And just encourage you to ask any questions that you want to ask in the Q&A box. But in anticipation for some questions to come, I thought I would start us to talk a little bit about source control. So we've focused more on antibiotics, which is because I guess the 3 of us that spoke don't really perform source control. We perform antibiotics and so on. So I was just going to bring Lindsay on to talk a little bit more about really where you think the NELA data shows we have something to gain in terms of timely source control. Lindsay, did you want to say something about that?
Yes, I think when we've looked at the data set this year, we've sort of seen that those patients who are most urgent to get to theatre in quite a timely fashion. And it's the group that sort of seems to be a 6 to 8 hour timescale to get to theatre that may fall between handover periods that don't get to theatre in such a timely fashion. So really interested to hear both presentations of Ron and Nurani, because what I'm interested from a surgical perspective is how can we highlight these patients sooner to surgical teams? how can we instigate and implement their antibiotic therapy earlier at front door, because our NELA dataset really focuses on time from decision to surgery moving forwards. And what I'm really interested on is what happens before that. So what happens before our decision to operate, what management plans are being put in place, and what treatments are being put in place. So I'd be really interested to hear from both of you what you think your roles, particularly from an emergency medicine point of view, would be in that, Narani.
So yeah, absolutely, our abiding duty is to get the patient the care as soon as possible. A lot of it hangs on diagnosis. Sometimes the patient is not obviously sick, they don't obviously have peritonitis, and that's why we use the red score just to look for the source. We do a CT abdo pelvis if the source of sepsis is not obvious on just chest x-ray. So because the vast majority, or 50% of our patients, have a pneumonia. So we try. I think we probably need to look at the detail of the different cases that you're highlighting, and we can work out how to get them to surgery sooner.
And I suppose from a pragmatic perspective, I mean, the red score looks fantastic, but it's not something that's done by a triage nurse, is it? It kind of goes beyond that immediate triage. So how do you flag those patients quickly at triage for them to be able to be seen by a clinical member of the team that can then complete all of the assessments required for a red score?
So it's on the news to score of 3 or more. That is the most sensitive. The specificity isn't high, but it's the most sensitive. So that automatically should trigger patients to be screened for sepsis. And if they are sick, if they show signs of, if they're hypotensive, they should get the antibiotics immediately. If they are not, we have a bit more time to see what the blood tests are like, and then refer them on and deliver antibiotics appropriately.
Ron, did you want to come in on that?
Yeah, thanks, Narani. So I too like the red score, Narani. I think where that works, that is a safe and effective way of triaging and prioritizing. Absolutely get that. I think I'd be concerned about rolling it out across an entire hospital, simply because I can't pretend that there is brilliant evidence to say thou shalt give antibiotics within the first hour to patients with sepsis. But on the wards, if you don't say do it now, it will never happen, and it won't happen until the following day. And so, you know, in an ED, we can absolutely reassess over a few hours with bloods, but on the wards, that doesn't happen. But I think, you know, the red score is a welcome introduction, and if it's working, which it clearly is, that's fantastic. I think the second couple of things to say on this, Lindsay, obviously this has to be a multidisciplinary management of these patients. We're often involving, of course, interventional radiology, at the very least non-interventional radiology. We're often involving intensive care. I think we need to be more direct and prescriptive as to whose responsibility the basics of resuscitation are. And obviously the source control will be you or IR, but the pathogen control will be the anaesthetist or the intensive care team or the emergency medicine team. And it might vary in solution from hospital to hospital. I just think we need to be prescriptive about it. The third thing, we can't forget that the patients we're talking about today have high risk of fungal infection, particularly if they've had previous GI perforation. And so we need to think not only about antibiotics, particularly when there's risk factors.
Thanks, Ron. Lindsay, I wonder, to me, the urgency of CT scanning comes into this too. I wonder, certainly, I guess, take people to the correct type of source control based on an urgent CT scan. Now, I know Narani, we in St George's have the benefit of a CT scanner right by the ED, and we're quite lucky in that way. I often think that our access to CT is pretty good, but just wonder if you could say a little bit more about what we see in the data and how the access to CT scans might be a factor here.
Yeah, so I think it's quite a broad and generic term, isn't it? Access to CT scanning, and what does that really mean? So what we look at in the data set is the time from CT to the time of report, and that's not necessarily where some of the delays in the pathway are. So what time is the CT actually requested, and who requests it, and what's the process within the organisation to get these CTs requested? Does it have to come from a senior clinical decision maker in the emergency department? Can it be an advanced care practitioner? Can it be a doctor of any level? So those are the things that we need to look at now. What are the organisation's processes in terms of requesting CTs for these patients? And we're quite clear in our data set about those with suspected sepsis and those with not. But what I'm interested in is those who are at risk of developing sepsis, because all these aggregation of small delays in the patient pathway ultimately results in what can be quite a significant delay, and then results in us as a surgical team operating on patients in the middle of the night with perforated ulcers. They may never have developed sepsis in their entire pathway, but they may have had a significant delay to get into theatre because of delay in CT request or delay getting to CT from the time of request. So those are the sorts of things that I think we need to be looking at moving forward for our patients with sepsis.
Yes, I suppose you have that. There's almost two things you need to get urgent source control underway: is that senior decision maker, and then the in most places, I guess, the confirmation, radiological confirmation as well. I guess these things run parallel to antibiotic prescription, don't they? And I guess a lot of our conversations around both source control and antibiotic prescription, I think Nirani described it, but both of you described it very well. When it's obviously sepsis and they're, they're out on their legs and they've got skin color changes and they've got altered mentation, that's pretty, that's pretty barn door, isn't it? But I guess the purpose of the senior decision maker in the early assessment would be mainly around those ones that don't fall into the barn door category. It's those patients that fall, some other way. Nirani, would you like to say something about how you encourage that senior decision maker to come in and see those, I don't know what to call them, in between cases?
So we're fortunate in our department that there's a consultant on 24/7. So, and there is a registrar on as well. So I hope it's not a major issue in our department. We often do refer patients to the surgical team and organize the CT scan in parallel so that there is no delay to the decision should they need to go to theatre. So hopefully, and all cases where juniors see anyone below CT3 and below, they are all discussed with the consultant on the night shift. So during the day, more likely to be discussed. So hopefully from our ED, there shouldn't be a major issue, but of course there are some cases that escape the net.
Always. And I guess around the RED score and the criteria, there is, as Ron describes it, to empower somebody to bring a senior decision maker into that conversation. Yes,
and what the RED score actually does is it quantifies that patient's level of sickness. It quantifies the mortality rate, and then it empowers them to have that conversation early and refer to ICU early. Because otherwise it's always, oh, they've got a bit of a lactate and a bit of this and a bit of that, and the thing just slips. But whereas if you bring the RED score in and they can quantify that level of sickness, they will escalate accordingly.
Yeah. Ron, do you want to come in on that, about empowering our senior decision makers to come down early?
Yeah, I think that's exactly what this is about. I think we're all saying the same thing. I describe them as the grey area patients. When someone's very, very sick, it's usually pretty obvious. When someone's very, very well, it's usually pretty obvious. It's the ones in the middle who fall through the hoops. And I'm sure that's what the RED score you know, to the best of our understanding at the moment, adequately addresses. It tries to identify those people, but it's around the actions in those people with the lower red score, and remembering that people come in having suffered deterioration at home, but they often continue to deteriorate in hospital. And I think it's really important that we look at the whole pathway, so that for the patients who potentially might fall through the net once they're disposed of to the ward, that there is a process to follow, and that if we haven't chased antibiotics within the first hour, that we set perhaps a time limit within which those decisions should be made, which might be 6 hours or something of that sort. And, you know, that we understand the systems integration and the whole pathway. I think that's really important. Narani, quick question. Do you use point of care tests for the albumin and the INR side of things? Obviously,
no, we don't.
Right. Okay. Yeah. Because I think in some more provincial hospitals like mine, where we send bloods and they go in a van to the main hospital in the city centre, that presents its own challenges in terms of timely decision making.
True, but the albumin and the INR are just 2 points on a 12-point scale. So.
Yeah, of course.
I think that's a really good point, Ron, as well, about organisational infrastructure, and we really need to individualise how we're managing these patients within the restrictions of the organisational infrastructure. And it's important to remember that just because we say, oh, this patient needs to go to theatre, that's not a smooth path without any resistance, you know, that not all of the time, or we have an empty emergency theatre with a full scrub team and an anaesthetist raring to go that says, yeah, bring the patient straight up. You know, there are delays that occur from that moment as well. And so that's why it's really important that we address all these issues in a really timely fashion.
Yes, agree with that. It's really 1 point on the pathway, and that kind of, I suppose, part of the value of that senior decision maker is that they often can unblock some of those other blocks, can't they, if they're involved? Sadly, people will answer the call of a consultant telling them to do something a little bit more readily than others. And I guess what we're all saying about the data, and I should also add in there calculating the risk of death for these patients using the NELA score or something for emergency laparotomy also empowers you to say, well, this person has, you know, 10%, 15%, 20% or more mortality, that mobilizes the team for you. So we've only got a few minutes left. I'll give the last few words to Lindsay just to talk about, we talk about a little bit in NELA recently about the bookends of the emergency surgery pathway, with our bit in the middle in the operating theatre, but the importance of the start and the end, I suppose, today is obviously focused on what happens in the early parts of that pathway. So just a few key messages from Neela about what we think are the most important things for our delegates to look at when they're looking to improve their pathways.
Yes, I think this is really where we're coming to now, isn't it? That we need to really look at the pathway, and we need to really recognise that our emergency laparotomy patients are not all starting from the same starting point. Some of them have been unwell for a few hours, some have been unwell for a few days, and some for a few weeks. And so where they are in terms of their baseline physiology, their nutritional status, all of those things all have a role to play in terms of how they're going to do throughout the entirety of their pathway. And so as clinical teams seeing those patients at presentation, whether it be via primary care referral or emergency department presentation, or the sickest of patients coming in via our ambulance service, we've all got to really be aware of that. And so I'd quite like to see more multidisciplinary engagement in terms of that early part of the pathway at the point of presentation, and that really if somebody's presenting with acute abdominal symptoms who we feel is either has sepsis or is at risk of developing sepsis, then that really needs to trigger a series of steps within the limits of the organisational infrastructure to manage those patients as best as possible. And I think it was important as well what Carolyn said about, you know, mentation of patients. And so post their procedure, they're often quite unwell at the beginning of the pathway. And in some of the PPI work that we've done recently, it was a really common theme that patients, certainly those patients who are normally quite young, fit, healthy, active, really struggled psychologically in the post-operative period. And so whilst we term their pathway as a success and that they've survived and isn't that wonderful, they're discharged home really without any sort of significant support. And that's a really, really common theme that came across. So I'd really encourage people to look at particularly the front end of the pathway, particularly around patients who are at risk of developing sepsis, but then also start to consider what the post-operative plan is beyond discharge for these patients, because a lot of them have a really rough time.
Yes, they do, don't they? Thank you for that. Maybe we should have a "Could it be Neela" campaign. No, I'm only joking. That belongs to you, Ron. That's okay. So thank you very much for everyone who's both attended and for our speakers, Narani and Ron. And thank you, Lindsay, for joining us for this plenary discussion. I've very much enjoyed it. Just a reminder to those who've attended, do fill in your feedback for us. Join us on our future webinars. Thank you very much and have a good afternoon, everyone. Bye-bye.